Now we have Dr. KAUSHIK Murali, who is the president of Shanghai Foundation. Shanghai Foundation has got a huge lot of branches across India. He's in addition a pediatric ophthalmologist and anterior segment surgeon. And I request Dr. Kaushik to speak on see what would you do, what would you think of when you get severe postoperative inflammation on the first postoperative day. Kaushik, please.
Thank you so much, Srini. I would like to acknowledge my colleagues, Dr. Simran and Dr. Minija, who helped me with some parts of this presentation. So we are always scared, or it's our biggest nightmare, to have a severe post-op inflammation, and we are a training center. So invariably, on a day, we would see cases like this where you're completely confused and at a loss trying to understand what to do. So when you see this kind of an inflammation, first thing that happens is you panic. You panic because you're worried what your boss is going to tell you. You panic what the patient is going to tell you. And then there's such a huge pressure that we put on ourselves in terms of the expectations that we set to the patient, telling them that, oh, you're going to have crystal clear cornea, you can go home in 2 days, you can probably go play golf or go for a trip. So automatically that kind of puts that pressure on us and we go into a tizzy. It's good to just sit back, relax, identify what is happening, and then get on with it. So invariably, the inflammation happens because of a break of the blood aqueous barrier, and most research shows that this would get resolved in about 2 to 4 weeks of time. Uh, there is pain, there is decreased vision, and there is anxiety. Anxiety both to the patient as well as to the doctor when this happens. Some of the risk factors have been long operative time, prior surgery, intraoperative complications, and when you've done extensive or combined procedures, you are more likely to end up with inflammation. That said, on the first day when you see it, it's good to go back to the history to identify what has happened. So in a uveitic cataract, invariably you will see inflammation. So that is a given. So there is no point in you panicking if there already was a history of uveitis and then you've operated on that patient. So that is bound to happen. You would expect that the inflammation was controlled preoperatively. With new IOLs, we don't see too much of an issue, and there is a good postoperative outcome. However, in these patients, if it's a mild kind of an inflammation where you see grade 2, grade 3 cells, just prednisolone acetate 6 to 8 times a day that is tapered works well. You may have to put them on these drops a little longer. Where you see a fibrin membrane formation or something like a hypopion, giving a subconjunctival midricaine works. And again, you may need to increase the dose of steroids as a loading dose. Topical cycloplegics always help in terms of reducing inflammation. You could look at atropine eye drops wherever you think it is severe. More severe, oral steroids, 1 milligram per kg body weight has to be started. This is just a short video showing how the midricaine is kind of mixed and how do you inject it in. Again, typically most midricaine is made of a combination of 0.2 ml of lignocaine, 0.1 ml of atropine, and 0.2 ml of adrenaline. Uh, Rarely also you can mix in dexamethasone. Again, that is given at about 4 milligrams. You anesthetize the inferior fornical area. You could put a plug there. Ask the patient to look up and you could inject it. You could do it under naked eye. You could do it on the slit lamp too. Making the patient lie down is more sensible way of doing it. There are reports of even atrial fibrillation happening after injection midricaine is given. So don't take this particular step very lightly. The second part of it is to go back and look at the OT notes, assuming that you're not the surgeon and somebody else has done it. Uh, you would see probably some residual cortex that is triggering it, some leftover viscoelastic that is causing this. The question then comes saying that, what do you do? So when do you go and re-intervene? With every re-intervention, there is a possibility of other complications happening. So when you see a residual cortex that is probably in the visual axis and not going away, or a significantly large amount of chunk, it may need a aspiration. Otherwise, conservatively managing it would allow this to be resolved over a point of time. What scares us more is seeing a cornea like this, where you see it anywhere between 12 to 48 hours. Typically, this is because of toxic substances entering the anterior chamber that causes a sterile, non-infectious kind of a response. Here, you would see decreased visual acuity. You see a limbus to limbus corneal edema. There is a raised intraocular pressure. You could see a hypopion. Fibrin could be there. You see an irregular pupil, and patient will have mild pain and redness. Uh, the question then comes saying that where did it come from? Typically, it can come from 4 different areas. It can come from the surgical instruments because you've not you've left over some enzymes, detergents that have not been removed out. Endotoxin contamination can happen after sterilization. Intraoperative fluids, intraoperative consumables like your viscoelastic have been contributed. Very rarely, postoperative medications can also cause, but that's not so common. Uh, some kind of a very simple kind of a flow chart is share information with other colleagues, find out if this is an isolated attack. If there are three or four who are having it, then probably there's a common source. Look for any recent changes that have happened to the consumables, and then you start looking at it. Uh, Microbial study, again, in the first day seeing such an inflammation, unlikely to be an endophthalmitis, unless it's a very fulminating kind of a picture where you're suspecting something like a pseudomonas infection. But otherwise, it happens. Unfortunately, we don't have any registry per se for TAS, so information that gets shared is very little. But go back to your alumni group, share it with there. If there is a local city group, talk to colleagues and find out whether TAS is happening. So again, the question comes: very severe inflammation, TAS or end off? Well, as I mentioned, first day seeing endophthalmitis is not so common.